Spinal manipulation might be one of the most misunderstood tools in orthopedic therapy. For decades, it's been surrounded by fear, myths, and controversy, sometimes with good reason. Yet the research is clear. When applied appropriately, it's safe, effective, and can make a real difference in patients with musculoskeletal conditions. The problem? Most physical therapists aren't using it, and patients are missing out. And even those who do utilize it, they aren't using it enough. So my goal with this video is to get physical therapists manipulating more. To do this, we'll be cutting through the noise, look at what actually happens during a manipulation, and show how to integrate it into your practice with confidence. Spinal manipulation has been around for decades, yet its reputation remains, let's say, complicated.
All right, take a deep breath inside profile. Take a deep breath in and deep breath in, deep breath. Deep breath in and deep breath in and all right, take a deep breath in and
viral social media clips, sensational headlines, and poorly executed techniques have distorted the public's perception, and in some cases even led medical professionals to recommend against its use. Too often, misconceptions and fear overshadow the facts. But here's the reality. When performed appropriately, research consistently shows that spinal manipulation is not only safe, but also an effective treatment strategy for a wide range of orthopedic conditions. So what actually happens when a joint is manipulated? The high velocity, low amplitude thrust moves the joint slightly beyond its normal physiologic range, but well within its anatomical limits. This produces a rapid stretch of the joint capsule, resulting in a cavitation, the familiar pop sound, not bones grinding, but a pressure shift as gas bubbles and synovial fluid collapse. From a mechanical standpoint, manipulation helps release restrictions, restore joint motion, and reduce stiffness in surrounding muscles. But the most clinically significant effects may be neurological. The rapid thrust stimulates high threshold mechanoreceptors in muscles, ligaments, and joint capsules, sending a burst of sensory input to the spinal cord and brain. Research shows that manipulation can reduce pain through descending and altered nociceptive signaling, activate inhibited muscles, particularly the deep stabilizers like the multifidus, the glutes, and transversus abdominis, which often show delayed activation in low back pain. Improve mobility not only at manipulated segments, but regionally through reduced guarding and improved muscle tone. Enhance sensory motor control by recalibrating how the central nervous system interprets joint position and movement. Facilitate faster recovery when integrated with exercise, especially for acute and subacute pain conditions. But here's the critical piece, and it's important for both clinicians and patients to understand. While the benefits of manipulation are real, they're also time-sensitive and patient-specific. A well-executed manipulation creates a short-term window of opportunity where mobility improves, pain is dialed down, and reflexive muscle activation resets. Research suggests that this window is open for only about a couple hours, sometimes up to a day or two. That means the real value of manipulation isn't just in the adjustment itself, it's in what you do afterward. This is the time to load, retrain, and reinforce proper movement patterns, so patients can build on the immediate gains and make them stick. Now, all of that sounds great in theory, but what does the evidence actually tell us? Well, for low back pain, a large JAMA systematic review found that spinal manipulation therapy provides modest but clinically meaningful short-term improvements in pain and function for acute presentations, with mostly minor and transient side effects like soreness or stiffness. Our own profession's JOSPT Low Back Pain Clinical Practice Guideline, released in 2021, is even more specific. Physical therapists should use thrust or non-thrust joint mobilization to reduce pain and disability in both acute and chronic low back pain conditions, usually alongside exercise and other active strategies. This is an A-level recommendation, meaning it's supported by high-quality evidence. Other professional guidelines reinforce this. The American College of Physicians lists spinal manipulation as a first-line option for non-invasive care for acute and subacute low back pain. For neck pain, the Neck Pain Clinical Practice Guideline, released in 2017, recommends thoracic manipulation, and, where appropriate, cervical manipulation or mobilization, combined with exercise for patients with mobility deficits or neck pain with headaches. The key takeaway? Spinal manipulation is evidence-based, guideline-supported, and safe, but it's not a standalone solution. Manipulation doesn't rebuild strength, retrain motor control, or correct the movement habits that perpetuate pain. Without exercise, education, and functional training layered on top, gains from manipulation often fade, leaving patients chasing repeated adjustments for temporary relief. Now, if spinal manipulation works so well, why don't more PTs use it? Well, the simple answer: confidence and experience. Limited training, lack of mentorship, and lingering safety concerns create real barriers. And to highlight this, surveys show that over half of PTs treating mechanical low back pain use thrust manipulation in only 0 to 25% of appropriate patients, even when the evidence supports it. For students, whether they get hands-on experience often depends entirely on their instructors. Without early, practical exposure, manipulation rarely becomes part of a routine practice. One reason many physical therapists hesitate to perform spinal manipulation is safety, but the evidence is reassuring. Serious complications are extremely rare when manipulation is performed by trained clinicians. In one large registry of nearly 1 million chiropractic visits, only 2 severe events were reported, both rib fractures in older women with osteoporosis. And there were no strokes or cases of cauda equina syndrome. Even in seniors, randomized trials report no serious adverse events. Cervical or neck manipulation often gets a bad reputation due to the theoretical risks to vertebral arteries. Yet the data shows serious neurovascular events occur in only 5 to 10 cases per 10 million. Most side effects are minor temporary headaches or neck stiffness that resolves within a couple hours. To put this into perspective, non-steroidal anti-inflammatories, a common alternative to orthopedic conditions, carry far higher risks, including peptic ulcers, GI bleeding, kidney injury, and cardiovascular events. Serious complications from NSAIDs are thousands of times more common than those from spinal manipulation. Now, some of you might be thinking, sure, there's a small risk, why not just stick with treatments I'm comfortable with, like massage or dry needling? They still help reduce pain and improve mobility. The reality, relying on only soft tissue strategies means you're likely leaving value on the table. For low back pain, massage and manipulation both reduce pain, but manipulation can deliver faster short-term gains in mobility in those with mechanical spine pain that massage or exercise alone can't match. One study found that patients with low back pain who received only exercise were 8 times more likely to worsen after just 1 week compared to those who received manipulation combined with exercise. Neck pain is similar. Both approaches improve pain and function, but high-velocity cervical or thoracic thrusts speed up range of motion gains, helping patients progress faster in rehab. Some conditions respond especially well to manipulation. Cervicogenic headaches, for example, consistently show greater reductions in pain, disability, and headache frequency compared to massage or mobilization alone. Even better, combining manipulation with exercise, massage, or dry needling often produces synergistic effects, better outcomes than soft tissue strategies alone. So with all that being said, who stands to benefit the most and when? Well, for low back pain, early responders typically show a fear avoidance beliefs questionnaire work score under 19, symptoms lasting less than 16 days, no pain radiating below the knee, at least one hypomobile lumbar segment, and at least one hip with internal rotation greater than 35 degrees. These criteria, captured in the lumbar manipulation clinical prediction rule, identify a low-risk, high-yield window where manipulation can rapidly reduce pain and restore motion that you can reinforce with targeted exercises. For neck pain with mobility deficits or neck pain with cervicogenic headaches, thoracic manipulation paired with cervical mobilization, as well as deep neck flexor and scapular exercises, is usually the starting point. Cervical manipulation is appropriate when exam findings support it and safety screening is clear. The cervical manipulation clinical prediction rule identifies patients most likely to respond with short-term improvement and includes symptoms less than 38 days, positive expectation for manipulation, side-to-side cervical rotation differences of greater than 10 degrees, and pain with lower cervical posterior to anterior pressure. Using these guidelines helps tailor care to the patients most likely to benefit, maximizing effectiveness while minimizing risk. But think of these prediction rules as probability enhancers, not gatekeepers. They increase the likelihood of a strong response, but they don't define the only patients who can benefit. The reality is, any patient with mechanical pain, symptoms that change with movement or position, can potentially benefit from spinal manipulation. It's not just about the classic low back pain scenario. Think about an overhead athlete struggling with scapular control, someone with pelvic floor dysfunction due to increased tone of the pelvic floor, or even a post-op patient dealing with muscle inhibition. It's one of those tools that, when used appropriately, can help patients move better and recover faster, and that goes way beyond just getting someone out of pain. That said, patient selection is everything. Not every patient is an ideal candidate for spinal manipulation, and using it in the wrong context can reduce its effectiveness, or worse, increase risk. Beyond the clinical prediction rules we've already covered, the mnemonic "My monkey is not scary" promise offers a simple, practical way to guide safe and effective decision making. Plus, it's fun to say. M stands for mild mobility deficits. Assess the patient's range of motion. Manipulation is appropriate for mild mobility limitations, while more severe mobility loss may indicate structural issues or more serious underlying pathology. The other M reflects mild to moderate pain, the pain range that is best tolerated for spinal manipulation. If pain is severe, the patient may not tolerate the technique and outcomes can be compromised. I stands for irritability. Low irritability is essential. Symptoms shouldn't flare dramatically with movement. High irritability patients may need gentler interventions first to avoid exacerbating pain. N stands for neurological. Neurologic exams should be intact. Sensory deficits, weakness, or abnormal reflexes suggest underlying pathology. Manipulation in these cases can be unsafe. S stands for spasms. Mild spasms is acceptable, as manipulation can help relax muscles, but severe spasms may impact the success of the technique and requires preparatory techniques to reduce muscle tension. P stands for pre-manipulative hold. Test tolerance to positioning. Minimal discomfort during the hold predicts that the patient can safely receive the thrust and tolerate the technique. Using this mnemonic, we can identify patients most likely to benefit, those with mechanical pain, limited mobility, or even movement coordination impairments, while avoiding clear red flags such as structural instability, severe osteoporosis, fractures, systemic signs, or progressive neurological deficits, as these conditions increase risk and reduce effectiveness. All right, this is where you come in. How do you take the practical steps to make manipulation a routine, safe, high-value part of your plan? Well, step one, identify the impairment. Pinpoint the primary movement dysfunction, limited range of motion, pain with a key task, or muscle control issue. Combine your movement-based assessment with passive intervertebral motion testing to locate the segment or region that reproduces or influences the impairment. If symptoms are too irritable or you can't localize it perfectly, start regionally. For example, thoracic techniques for neck pain or lower thoracic and hip for low back pain, and reassess as you go. This ensures you're targeting what you can realistically change today. Step two, choose the right technique. Match your manipulation to the impairment and the patient's tolerance. Think precision, not brute force. Step three, communicate clearly. Build trust and set expectations. In my opinion, a lot of adverse responses that happen in physical therapy is due to a communication breakdown. So a little spiel you can say is, I'm going to use a quick, precise stretch to help address your issue. Some people may feel a little sore afterwards, like after exercise, but it usually resolves within 24 hours. We'll set up the technique, check in with you, and then follow up with exercises to maintain that motion. Step four, close the loop. Reassess the asterisk sign immediately after the technique and exercises. Document any changes and adjust your plan accordingly. This feedback loop ensures the patient receives maximum benefit every session. In step five, reinforce the gains. Follow manipulation with 2 or 3 exercises, targeting the specific movement dysfunction. Manipulation opens the door, exercises lock in the gains. So now that you know who responds best and why spinal manipulation works, it's time to make it a reliable, high-value part of your practice. Understanding the theory isn't enough. You need actionable steps that build skill, confidence, and consistency so you can deliver these benefits safely and effectively. So start small. Focus on mastery, not volume. Pick one lumbar, one thoracic, and one cervical technique to really learn this quarter. Co-treat with an experienced colleague, film your setup, and track outcomes. Repetition isn't just practice, it sharpens your clinical intuition, builds skill, and boosts confidence. And put safety first. Make resources like the IFOMP screening second nature for neck and headache patients. And follow a clear playbook: indications, contraindications, consent, and follow-up exercises. Confidence grows when you know your patients are safe. And make it a point to do this during the week. Take action, review your caseload, and ask, which patients could truly benefit from manipulation, and why haven't I applied it yet? Screen them, deliver the thrust, reassess, and layer in 2 to 3 targeted exercises to lock in the gains. I challenge you to do this with 5 patients over the next week. You'll notice faster improvements in your skill, smoother sessions, and your confidence increasing. So remember, spinal manipulation isn't just a flashy technique. The real risk isn't performing it, it's skipping it when it's actually indicated. Underusing manipulation can slow patient recovery, increase disability, and limit your outcomes. And when done correctly, it's safe, effective, and a high-value complement to the exercise and education you provide every day. Smart screening, precise techniques, and consistent follow-up help your patients move better, hurt less, and get back to what matters most.